everyone, this is the only thing I wrote down for this podcast, is everyone associates complexity with advancement, and
Hmm.
that's not the case with
Yeah.
medicine over most things.
Yep.
You look at like our health outcomes. We keep sicker people alive longer. We
Yep.
do not have healthier people.
Hey. Very
Hi.
nice. So, this is the first will hopefully be a series, um, kind of fleshing out some concepts in the videos that I've made already, and hopefully, um, I don't know, engaging in a higher level of detail and just talking through with you, um, what whatever concepts flow our way. And so, wanted to start with the testosterone video, which we'll put a link in the description below, and maybe just talk through, even just talking about your first impressions of it. Start there.
Man, my first impressions. My first impressions were my first impression was bold. Like
Mm.
castrate yourself for the
Yeah.
sake of longevity.
Right.
That's a pretty profound statement. I feel like that's pretty edgy. That's a
Yeah. A little bit. Not. I mean,
But ever since we became acquainted and I was thinking about your practice and this day and age, whenever you see like maximizing health and fitness, it's synonymous right now with the TRT clinic.
yeah.
That seems to be just where so many people are going. And I feel like your video really shared and showed a different side of testosterone than what I would say would be the popular opinion right now.
Yeah, and I think that's kind of an interesting thing. One of my ongoing irritations in some level in the wellness space is the and it's a cultural phenomenon too, but I sort of refer to it as the fetishization of youth, meaning whatever your lab values were at 18 is the definition of what is healthiest. And that's not necessarily the case in a variety of different ways. And one of the things in the testosterone video I talked about was like, well, it could be that nature has optimized us for different things at different eras of our lives. And in fact, it may be trying to kill you off at 18. Like that's nature's best interest is to get 18-year-old men to sort of weed themselves out. And so, that may not be the optimum testosterone level we should be shooting for, first of all. And second of all, I think the other one that bugs me is, you know, the confusion of a metric with a cause. So my classic example of that is like if you look at aging and you say, okay, total number of hair follicles that are active per age, right?
Right.
Well, cool, but a hair transplant isn't going to do shit for you. Like, you know, sure, hair follicle count declines reliably with age. It's a marker of aging, et cetera, et cetera. That doesn't mean that hair transplants are going to be longevity factors, right?
Right.
And so, I think the confusion there is pretty big. I see a bunch of my patients like trying to strengthen their hand grip because there was a study that hand grip strength was correlated with longevity, and the point of the study was that strength, muscular strength, was associated with longevity, and it just used hand grip because it was the easiest to measure, right? It was an easy marker of total body strength rather than doing some actual complex measurement, right?
I think that's really interesting. Couple things that just really resonate with me deeply, and it's really come to light ever since I started. We became acquainted. We're
Yep.
friends, but I
Yeah.
started following all your material, and it's really changed the way that I thought about. So some of these studies, like the hand grip one, because I've fallen on both sides of this. I have hand grippers in my car. I didn't
Sure.
know that was going to be the fountain of youth. I didn't realize that was going to turn me back into
Sure.
18. Not to mention, like, oh, see, this is going to be good. With the hair follicle one in particular, have you read about minoxidil and low dose, transitioning villus hair into terminal hair follicles?
I have
It's
not actually.
it's pretty
Okay.
interesting.
Okay.
So that was just
Interesting.
random
Yeah.
tidbit of information.
Okay. Yeah.
the 18-year-old testosterone comment, you know, just it just takes, we all become so invested in like a consumeristic way to that we go about everything. Like we're constantly in a consumer-based mindset. And so when people present something that you would like who wouldn't want to be, you know, live forever, be younger? Whenever you start looking at that and how it applies into some of the endocrinology, first off, there's nothing that I want from when I was 18 that I don't have now. I
Yeah.
made poor choices, and then, you know, maybe you could argue that some of my testosterone levels at that time correlated more to some of the, I would say, short-sighted, definitely not biologically fit decisions that
Yeah.
someone can make.
Totally.
So I don't know how that one is.
And I
We
mean, I
make it
think that,
so lucrative.
I mean, that's also my joke, you know, and I got, unfortunately, I told you Brian Johnson's name wrong in the testosterone video. I referred to
That's
Brian Armstrong, who's CEO of Coinbase, and Brian
that's what I
Johnson is yeah, no, and I completely confused that. So apologies to Brian Armstrong. But no, Brian Johnson is the, you know, another tech millionaire, whatever, spending a ton of money on his like, you know, anti-aging whatever thing, and it's a great example. You know, he's using some measure of biological age, none of which are validated, right? None of which have been actually shown to correlate to mortality. Like there was a great study actually on, and we can talk about this more maybe in another podcast, but on biological aging metrics, and they took 11 different measures of biological age that are available, and none of them correlated to each other, and none of them correlated to visual age, none of them correlated to outcomes over 10 years. And so it's like, okay, well, what are you really measuring, right? That's the first problem. The second problem, even if you're right, if you're trying to get yourself to be biologically 18, what makes you think that neurology is not going to follow? You're going to maintain the wisdom and judgment of a 40-year-old, but magically your brain's going to be at an 18-year-old. Like that doesn't make sense, right? I think the whole goal is flawed at a very very deep level, but it pulls at us emotionally. If, and maybe this is a great place to take the conversation, if we have a fear of death, right, and we're looking for that fountain of youth, you said who wouldn't? And I got into this with a friend of mine recently too, on the Vervaeke podcast series. Um, it's interesting. I think the people that are most driven to live forever are the ones who would be the worst off if they got it. Meaning, if you waved a magic wand and said, okay, cool, you're going to live forever now. I think that part of what they're trying to do by pursuing the Fountain of Youth is to hide from their existential terror about the meaninglessness of their lives.
I watched the short on that.
Okay. Yeah, yeah.
That y'all put up, and I
Yeah.
felt I think it was something like, "I hope you leave with an equal amount of depression and anxiety." Something along that. We don't have much to offer here.
Yes. Yeah, yeah, yeah. I mean, it's an interesting. I mean, actually, so in this week followed up that thought actually in an unpublished podcast, which I need to post soon. But um, my friend Atif kind of made this point that like, look, if you were to live forever, if you do not have something meaningful to pursue, you would you would develop a terror of leaving the house because you would be losing thousands of years of life if you got hit by a car or if you know got injured in some way or got hit by a meteor or whatever the deal was. And so the percent, like if all the deaths in the world are only due to homicide or accident, you know, accidental, then you would develop a terror of the other people. You would develop a terror of anything that could deprive you of that immortality because you would have nothing meaningful to make it worth it. Like, what would it be? What would make it worth it to you to take the risk of dying?
I mean, I think that's a really valid stance on it. But I give the average person, which I would definitely fall under that bell curve, a little bit more credit, especially when it comes to the medicine part of this. And my biggest takeaway through all of the River Rock medical stuff is, you know, my background being biology and chemistry and reading and being in the lab and and being a part of the industry on that stuff is I've had to reevaluate how I read studies and
Mm-hmm.
how people utilize studies. So, a big conversation in my personal life recently has been how many things have I gone around saying since, that I learned to talk that are pretty arbitrary. Whether that's some of the faith-based stuff or more recently, like how many things that I said that, I heard a professor, maybe just say in
Mm.
passing and I took as a fact.
Yeah.
So I do not fault the greater population whenever their doctor's like, this is good for you.
Yeah.
Or
Yeah. Yeah.
and more importantly around here, like, and even through my travels through the US, there are very few endocrinologists that I have seen versus mid-level practitioners that are involved directly in the care of these patients. So there is there's something there that I think needs to be identified because, like as many of the studies with multivitamins, fish oil, some of those things, we're told, this is what you need to be healthy, some of these
Mm-hmm.
micronutrients. And,
Mm-hmm.
looking back at your diet podcast, like,
Mm-hmm.
we're going to tell a patient with a BMI of 35 that they need to up their omegas and make
Yeah.
sure that they're getting enough, B12, but we're not
Yep.
going to talk about the fact that, they need to lose 40 or 60 pounds of visceral fat.
Yep.
And I think the testosterone thing has a lot to do with that because most people, it's a two-edged sword because people want the performance aspect because that's pretty undeniable. And
Sure.
anecdotally, it's definitely like every person who's ever spent time in a gym, there is a huge amount of people who are supplementing with steroids of various kinds, and there's an appeal to that. You can get
Sure.
bigger and stronger, but no one's telling you. You can't look at someone and be like, wow, like, your HDL's 35 and your LDL's 200.
Yep.
And I don't know if I can say that with you because I know how you feel about some of the cholesterol markers.
Sure. That's a
But
whole
if you
different
have,
conversation, but
right,
point taken. Yeah.
yeah, if you have Crisco running through your veins
Right.
for the cost or for the ability to put on a little bit more muscle, is that really longevity? What is
And
longevity?
this, yeah, I mean, so this gets into the video I'm currently working on. So, spoiler. But it's an interesting thing where we've talked about this at different times. Like the number one longevity metric is VO2 max, and
Right.
so the gap, the multiplier of longevity from the lowest VO2 max, less than fifth percentile, to the highest above 95th percentile in the population is like a multiplier of like 5 plus, right?
Wow.
It's huge. But it's diminishing returns. So from the 5th percentile to the 10th is a big jump, 10th to 25th is a big jump. 25th to 50, it's notable. 50 to 75 is smaller, so on and so forth. So from 90th to 95th percentile, it's not a big jump. Like
Right.
it's detectable. So here's and where I'm going with that is, from 95th to 99th or 99th to 99.9th, it's essentially minimal, right? And if you are a marathon runner who is trying to get from 90th or 99th to 99.9th, and your trade off there is strength, well, the multiplier on strength is 3.2. It's also a huge longevity factor, right? And so you do better to try to be in the 99th percentile of strength and the 99th percentile of VO2 max rather than trying to get just to the 99.9th percentile of VO2 max. And so optimizing across domains is going to get you further. And to your point, if you're adding testosterone to gain that little bit extra, you're already in the 99th percentile of strength.
Right.
Like, in those people, and the 99th percentile is not that high. like, it's just, from a weightlifter standpoint, like,
Right.
that's not, it's not huge things, right?
Sure.
And so if you're already there, then what do you can't pretend that you're doing something for longevity at that point, right?
Well,
You may be
see,
doing it for aesthetics. or
Right.
ego or whatever, and just you have to be honest that that's I'm and maybe and I think again people that pursue bodybuilding they want that's the area they want to make their mark in, they want to do whatever that's meaningful to them for whatever reason, then cool, they're explicitly saying I am trading off years of my life in order to pursue this area of greatness, right?
Right.
Cool, be explicit about that, but don't pretend like you're promoting longevity.
See, where I have not a difference of opinion, the average person, and we've had this conversation a lot, you and I, you see things and you see things from 10, 20 years of study, of statistics, of understanding, and you forget that for everyone who's not plugged into the medical field in some way, like if you were to come up to me and say, hey, this will add 10 years on your life, I defer to you. I defer to your
Mm,
knowledge. And so many of these people, I feel like maybe like deep down, like intrinsically, they're like, there's probably a compromise here. But the problem is the marketing of it right now. It's the fountain of youth. I mean, you can't
sure.
get online, you can't get on Snapchat or Instagram without some new influencer linking it to a new mail order, lab, peptides, testosterone, whatever you need.
Yep.
And they're all saying that, like, this is their secret. This is how they're getting, better results faster, as well as longevity.
Yep.
And the biggest part of your video that really resonated with me was that there was no decrease in cardiovascular incident shown in the studies.
Right. Right.
Well, that's not longevity. That is that's that
Right.
that would be the opposite of longevity because you're gonna die of one of two things: heart disease or cancer. I mean, I'm
Right.
pretty sure. And that's the other thing. I don't have to say, according to my medical advice, I love the impunity of being just a normal guy because,
Sure.
you know, my medical practice is not going to go, is
Yeah. Yeah.
not
Yeah.
upwards or downwards because of this. But I mean, pragmatically, you're either going to have some kind of terrible, tragic accident, which is so anomalous statistically, it doesn't even exist. The
So
majority of people aren't in urban areas in the world. They're not going to get plowed through by death by scooter is possible.
so actually, what's interesting is I think that and this is a fascinating topic to discuss, especially in the context of like testosterone and muscular strength. Is why is muscular strength so protective, right? Not because it reduces your cardiovascular mortality, it reduces your accident mortality. Accident mortality is significant in old age because people fall and then
Sure.
die. If you break your hip, like the mortality rate on a broken hip after age 80 is like 30%, 33%,
Right.
right? And so, no, the protection of muscular strength is to prevent accidental death. And it's not a small number. We just tend to write it off medically because we're like, well, it was an accident. That's not a medical issue, right? We demedicalize it, and so we safely ignore the numbers.
Well, so and I don't disagree. How many of those patients and we could talk about the COVID aspect of this, like where you're making a mortality association. Because if the 85-year-old falls and breaks their hip, they're not bleeding out. It's not some hematoma. It's not the actual broken bone, but there is a marketable decline in their health rapidly. Pneumonia, everything else that
Yep,
happens. But 100%, it's it's the patients who are in the best health before the accident who do the best after a
totally,
surgery. Well,
totally.
orthopedists they're spoiled by all the athletes that they work on because it pads their numbers. If,
Sure.
if I like whenever I had my knee done, I was up and walking. If I hadn't been walking for the 6 years or 6 months before then, that's going to skew my post-operative care.
Yep.
And
Well, and don't discount the mentality of the athlete too, right? Like a good friend of mine actually had ankle surgery recently, and but she's got that athlete's mentality. So when she's in rehab, she's working, she's pushing through pain. It's genuine work because that's the mindset of rehab progress, muscle gain, gain of function, all of that stuff. Whereas I don't know that I see that in the general population.
let's make a this could be a whole this is another one. Here comes another podcast right here.
Okay, fair enough.
So it's the athletic mindset because whether or not they're biochemists or exercise physiologists, they reconcile that their goals require a certain amount of trial, tribulation. Like it's hard. Athletes train hard. Successful athletes train very hard and push through those limits. Very educated people study very hard.
Mm-hmm.
It's a challenging. It's no one. I don't care if you've got a four digit IQ. Medical school's a grind for everyone
Yeah.
who goes through it. That kind of dedication, I feel like those people do well, that mindset does well across the entire spectrum of existence. The perseverance. And so, for instance, this weekend, my best friend's wife went into labor 6 weeks early.
Mm.
She had an emergency C-section, and this is, she is a Brigham trained anesthesiologist. She had a C-section and was up walking around like 8 hours later with a gram of Tylenol.
Mm-hmm.
She didn't want to go. She's like, this is what's best for me, for my family, for my health. And she was active until the day she had her surgery.
Mm-hmm.
But I mean, that's a large surgery. It's a big procedure. If
Absolutely.
if I had a uterus, if I was a birthing person, and
A
you were
birthing
to
person.
access that, I would I would need more than a gram of Tylenol, personally. But it's recognizing that, and this is like your mantra. This is one of your maxims. It's we have to do some work internally to modulate our outcomes. Everyone, this is the only thing I wrote down for this podcast, is everyone associates complexity with advancement, and
Hmm.
that's not the case with
Yeah.
medicine over most things.
Yep.
You look at like our health outcomes. We keep sicker people alive longer. We
Yep.
do not have healthier people.
Yep.
Pharmacology has come so far. Medicine has come so far. Imaging. And if you're to take and look at like a huge retrospective analysis, we're keeping sicker people alive longer.
Mm-hmm.
That doesn't sound like longevity and fitness to me. That doesn't sound like we're having healthier, happier people.
Right.
We have more disease states. We have more drugs that we're treating people with. And internally, I don't think people are willing to invest in the River Rock Medical type of treatment.
Well, I mean, I think that's kind of the thing is if you are going to be uncomfortable, right? You have to intuitively your brain is asking you why. Why are we this uncomfortable? Why are we suffering in this way? And if you don't have an answer for that, you're not going to do it. You're not going to stay with it very long. And so, yeah, when you're trying to get through med school, the reason you're willing to tolerate the sleep deprivation and the grindiness of the study and whatever is because you found the goal meaningful and therefore you're willing to put in the work. But that may not translate to the gym. There are plenty of out of shape doctors who don't work out and have difficulty working out because they don't know what that goal is. They don't have that sense of why am I doing this? What makes it worth it, right? And the that to me is the question that I try to help people answer is what would make discomfort worth it? Because if you want to get healthier, the pathway there is uncomfortable. Simple, often, but
Right?
uncomfortable, right?
See, and this is where I pick on, this is where your idealism just blows my mind. Because I feel like, whenever you see like that super overweight or like cardiologist who's smoking, do you think that's because he doesn't know that that discomfort would lead to a better quality of life, or is it just apathy?
I think again the notion of better quality of life is too poorly defined for him. I don't think he's thought carefully enough about what quality of life is, right? Or maybe or that's the other possibility. Or he has and what you're seeing is actually his optimum state, meaning who knows what his circumstances are for his family or for maybe he's supporting 40 people back in India and he's sacrificing his own health in order to work enough hours to and he just needs those dopamine hits and he's like fuck it, if I die at 55, I'll have spent my life supporting these people, and that is his optimum. Just like for a bodybuilder, it's like, okay, yeah, you're shortening your life to hit that goal, right?
Yes,
Maybe, I mean,
except so the bodybuilder's never seen anyone intubated. They've never seen heard someone's death rattle. They've never been around it. I think that all of those people are being led astray by this greater marketing, this huge populace of this is longevity, although we don't know what that means. We're not going to define it. Here, there are no accurate metrics. The science is incredibly poorly worded. And with the cardiologist, if he wants to make the calculated choice, and I can't believe I'm saying this, so be it. That is his choice.
sure.
But for the average guy who, because of the bro science and gym culture, decides to, you know, stick a needle in himself and shorten his lifespan by 10, 20, 30 years. I don't think there's any possible way they understand the gravity of those choices.
I think you're right. I mean, actually, so let's circle back to this. But one of my fun, fairly controversial points of view is that uh, informed consent is actually a myth, and it's just a legal fiction. But where I wanted to go before we talk about that is, uh, you had mentioned, I think, that you knew someone who you kind of shared the testosterone video with, and his response was like, "Yeah, but," and or not even wanting to watch it, or not even wanting to engage with it. I
I
thought that
had
was a fascinating kind of like. I don't know if you
it.
want to tell the
No, so it's gone.
story.
It's gone several ways because I attribute probably 10, if not 20% of the views on this video to me pulling people, like literally physically, like, hey, sit down with me. Let's take a gander at this. I
I
mean, I've
appreciate
spread
that.
it to at
That's
least a
good.
couple different countries. And it's been, I'd say I've had three or four general responses. The first one would be coming from like a medical community, and they loved it. They
Yep.
thought it was really insightful, that it fleshed out a lot of the kind of more empirical things that physicians see and put a little bit more statistical backing to it, as well as, I don't understand. I always, and it seems like a lot of practitioners, physicians, I should say, kind of tiptoe around some of these. Like they have no problem telling you, hey, smoking's bad, drinking's bad, but people aren't going to say that some of these longevity markers and some of these longevity supplements could be equally as bad.
Sure.
And so that was I got some very positive response from people in the community, and then there were the people who are not medically inclined will say, one of them, the most profound one, was I don't want to know. I don't want to
Yeah.
know.
I
Just
thought that was
complete.
the most.
Yeah. I
That's
mean,
the
and
most fascinating.
he is someone who I'm well acquainted with and has dabbled in all of the uh, underground lab kind of stuff for a
Hmm.
few years, and he just refused. He
Yeah.
just blindness. He just wants total blindness. He doesn't want to know. And then I had one guy who it brought like a lot of catharsis to. He's like, I'm so
Mm.
glad I never went down that road.
Mm.
He's probably early 30s, has been lifting for probably 15 years competitively, and he never felt comfortable making the step from natural to enhanced.
Yeah.
And
Yeah.
it brought him joy. He was like, I knew this. I knew this was
Yeah.
going to be bad for
There
me.
was some intuition there, right? It's like, yeah. And I think, I mean, everybody who has contemplated moving from natural to enhanced, whether they do or not, everybody pauses at that moment, right? And I think if there were no perception of risk, nobody would pause. Everybody would be like, "Yeah, okay, my newbie gains are over. Time to start juicing."
Right.
Like, right? Like you'd work out for a year and then juice. Like that would be the standard protocol that everybody did. But it's not. Like most people don't, or many people don't, because there is this intuition. Like, well, there's a risk I'm taking on here. I don't know what it is, but something is. because they see the bodybuilders. I mean, they see the Ronnie Colemans, and they see people after their bodybuilding years are over, and how broken up they are, and how once they stop taking supplement, like things
Right.
go downhill in different ways.
Well, so you still, and it's funny because I hope I'm, no, I don't hope I'm the only person, but you and I have contrary ideas on some things. Like right
Hmm.
now, I have a contrary opinion that you think that it's like from someone's, you just give people the benefit of the doubt when I don't. The biggest aversion, the thing that I know
Yeah.
that deflects most people from enhancing is a fear of needles.
Really?
Absolutely. Every
Oh
guy
my
that I
god!
just
Wow.
mentioned, I know people who are taking just egregious amounts of steroids. I mean, truly, like, grams. Whenever you measure stuff in grams, you're
Yeah.
getting
Jesus.
serious. And I know people who will keep their AST at about 200 just because they're not willing to use a needle.
Whoa.
And I've got guys who I've looked at it, and their steatosis, they have to get ultrasounds, and people are like, "Are you drinking too much?" And it's just abuse of oral steroids. And it's
Whoa.
so I have guys. I mean, and I can't believe I'm saying this. I've just known so many people who will vagal down, like they've tried to get an injection, and they'll have a vasovagal episode, and they're like, "That's what
Yeah,
kept
yeah,
me
yeah.
clean." And I'm like, so be
Oh
it.
wow.
Like, but it's not because of some forward thinking or altruism or like, who's gonna be able to take care of my wife and kids. It's
Yeah, yeah,
because
yeah.
they're too soft to stick a needle in their muscle, but they're willing
Wow.
to wreck themselves. And this is my last little tirade. I have seen blood work with an HDL of zero, zero,
Wow. I don't think I've ever
and
seen blood work with an HDL of zero.
and granted, like, I don't know if this was the single greatest laboratory in the world, but still, and it was just for research chemicals that you can just have
Hmm.
mailed to your door, and
Sure.
that was that was the quick fix.
I guess so. This is the thing that's surprising to me too, and speaks to I think some of these interesting dilemmas. Just like we talk about doctor who can tolerate the sleep deprivation to get through med school, but can't tolerate the discomfort of lifting. Similarly, these guys are guys who will tolerate the discomfort of lifting to failure repeatedly, weekly, like all the time, but won't tolerate the discomfort of a needle stick. Like that, like those are
It's
interesting things. Like that,
they really are, but and I'll
because needles. I mean, and again, career in medicine, it's its own thing. But like, I let nursing students practice the IVs on me. Like, I mean, and part of that's paying it back because I remember when I was in pre med and needed my needle sticks to practice, and various medical personnel were always the ones who kind of like allowed that practice to happen. And so, whatever, it's a cycle of life, I guess, in some level. But like, but yeah, it doesn't bother me. I mean, like, it's nobody likes having their vein cut, but like, I don't know.
I mean, it's just different people,
Yeah, yeah.
I need to plug my girlfriend on this because she's a physical therapist, has spent a lot of time in hospitals. She was, she is a good patient. She takes her medication as prescribed. But I mean, let me tell you, she will take a glass of water until she has to be hospitalized. She doesn't want to take medicine. She
Hmm.
doesn't like doing it, and the last thing she would take is an injection.
Hmm.
She hates needles. I mean,
Really?
and it's people have a true aversion to it, and I think that's one reason why so many like this is controversial. Let's just say like all the studies that were done and from some of the big pharma players, very few of them were dosing like they're trying to make it more and more tolerable and accessible to the patients. Because I'm telling you, if you pulled some of the transdermal stuff off and the pellets off, I guarantee we would see a huge decrease in people who are willing to be on testosterone.
Hmm.
Getting a little incision, every couple of months and having some pellets put in, or rubbing this gel on yourself isn't the same as let's aspirate this needle and give ourselves a big shot. and I think that plays into it significantly.
That's so interesting. Yeah, I'm fascinated by it because I mean, like even Ozempic, right? I mean, that's injectable. Um, I've, I remember I gave myself an IV, on several occasions because whatever needed, I'd thrown out my back or whatever, needed to give myself some mag or XYZ. And so, yeah, I've, whatever, I'll put a central line in myself, push come to shove. Like
Right.
but, I guess, yeah, I have maybe a more, I don't know why I have a more cavalier attitude towards that. Um, and yeah, I guess I always am struck by patients who are real. I mean, there's these, yeah, just what you're talking about. Now that you say it, I mean, I'm coming up with examples of patients who are really like big, strong guys. They work whatever, but like if we have to do an injection, they're like the
Oh,
amount of like pain perception seems to like for me it hurts way worse to squat to failure. Like that's a
oh.
much more painful and uncomfortable experience than
I
I
mean,
don't know
you're
for me.
100% right. These guys, because I have trained. I have one friend who is, she was an Olympia athlete, the greatest bodybuilding stage of all time.
Yeah,
I made it through 10, 15% of some of her workouts usually, and then I couldn't walk,
yeah,
throwing up, whatever it might be,
yeah,
vagueling down, couldn't stand up,
yeah.
orthostatic hypotension, the whole nine. And I see guys that have trained in that same way, and the discomfort they tolerate for that is unmeasurable. I mean, so much. But
So
when
what do
it
you
comes to
so what do you think that is though? I mean, why are different types of because I've attributed previously I said it was meaning, but this would have the same meaning. So this argues against my previous point. Like if you're like because it's the same thing, right? You're the discomfort of squatting to failure, the discomfort of the needle. It should be in service of the same goal. So if I had been right, then you would be able to tolerate both. But clearly, I'm off somewhere.
um now our entire perspectives are going to shift. I'm going to
Okay.
give humanity the benefit of the doubt, and maybe deep in your soul, in the most fundamental areas of your psyche, you know that pushing yourself hard is
Mm,
is worthwhile. It's how you separate yourself from the pack. It serves a purpose. There's utility to it. But the minute that you start supplementing exogenous, whatever it might be, it's no longer a you thing. It's no longer what you've done. And not to mention, like, I don't know, I'm really trying to go like full biological fitness. Fear of unknown. I mean, mankind did not develop in a way where inoculations have been a common part of what we've done. I wrote a paper on cocoa leaves and stuff in college and how certain people would use that. Different medical adjuncts, like medical botanical adjuncts. But maybe there's something about sticking a needle in yourself and injecting the unknown. I don't know.
well, I mean, I mean, I'm just trying to think of other forms. What are all the different forms of discomfort, right? So like pain, different types of pain. So this needle pain versus, muscular pain on some level. The discomfort of high heart rate of maxing out your heart rate. That's kind of a different discomfort. Nausea is a different discomfort.
Oh, so let me
Sleep
stop you right
deprivation.
there.
Yeah.
It's it's almost always the apprehension, the anxiety of those things that get people. Like look at people with shots. They will have vasovagal responses before, they will, get so worked up, hyperventilate, and then the actual little shot is nothing. It's the fear of it. And just like the
Interesting.
people,
Yeah.
anyone who's had AFib, they can give themselves AFib about talking about their AFib episode, and
Mm.
the pain, the associations that are there. So I think acute discomfort versus the more chronic look of it is different. I mean, I
No,
You
I
know?
think you're right. I mean, so one of the are you familiar with the big five personality types, right? The
Yes.
openness, conscientiousness, extroversion. What is it? Agreeableness and
Agreeableness.
neuroticism, right?
Right.
So one of the components of neuroticism, which is sort of sensitivity to negative emotion, is anticipatory dread. The degree to which you perceive anticipatory. So, I mean, a bit of a depressing conclusion if this is right. It may be just personality types. What we're seeing is people that are more prone to anticipatory dread are less willing to engage in these uncomfortable experiences. Although they also are the ones that benefit the most, because I mean, exercise we know has an anti-anxiety effect, right?
But Zane, then you also have to like again. I think so much of that, like the most anticipatory dread a person could undergo, would be from knowing the depths of their discomfort. I guarantee that the majority of non-prescribed or even prescribed people who are taking, say, testosterone by injection for aesthetic or athletic purposes, are not understanding what, like, you know, hepatoencephalopathy feels like, or what liver failure feels like, or what a stroke or a heart attack, or all the things. But if they did, and this was something I listened to last night from a very popular YouTuber who goes through all of these different crazy cycles and talks about the compounds, pharmacology. He had a friend who competed and front loaded a bunch of diuretics and almost went into heart and kidney failure. And now, since that time, he can't even get on TRT for fear of those things. So
Mm.
it's like it's always coupled. I think that the more you know, the greater it can exacerbate your fear.
It's an
Like,
interesting. I mean, I think there's some reality that I mean, I experience this a lot when I do my hospital shifts, right? In a couple different ways, right? It I always, I do a week in the hospital, 12-hour shifts. Modern hospitals are not like old school hospitals, right? In order to get admitted to the hospital, there has to be a reasonable percent chance that you will die in like the next, you know, 72 hours. like
right.
somebody is worried that okay, there's a 5 or 10% chance this person just might die, right? And so, you know, with that as the criteria, you are surrounded by the notion of death and debility all the time, day in and day out in the hospital. And so, certainly for my parents, it makes me like, okay, yeah, they're healthy now, they're doing well now, but what will this look like when the time comes? And then even for myself, I mean, I think I had the other day kind of a really visceral terror experience of imagining what it would really be like to be stroked. Like if I just can't move half my body, or I can't speak, or I can't engage in all the things that currently are fulfilling, right? And where would I find the courage to, I don't know, to participate in life if I really could not move? Like if you really put yourself in that mind state of like, okay, no, half your body's just gone. Like you are not walking, you are not talking, you're not, I mean, it's a pretty terrifying ex- like experience, and the people that have the courage to actually continue fighting through is pretty remarkable. And I don't know that I would immediately have that courage, but most people I think don't viscerally spend time really picturing themselves stroked or really picturing themselves,
Of
you
course.
know, with a heart attack or with whatever. And maybe they don't even know how. I mean, I'm obviously educated. I'm a physician, like whatever. I know what that looks like and all the different versions of it. So, um, but yeah,
Well, I mean, so much of that, Zane, it's you look at people, and that's why I feel the way I do, and while this testosterone video really resonated with me, is because for the average person, just like you said, like you're a physician, you can put yourself in those situations. You can, you know, you've studied, you've seen. Well, the average person that is, cranking their testosterone up to 1200 has no idea. I mean, they couldn't tell you what an NSAID was versus, I still have like every time someone, I mean, how many times have you gone through something and it's like, okay, well, take ibuprofen. They're like, well, I took Tylenol. It's the same thing, right? That's probably where most people fall as far as medical education goes. So to tell someone like, we really need to start talking about like hematocrit, some of the heme binding, like oxygen carrying capacity. What about like arteriosclerosis, peripheral artery disease? What I'm, if you have any predisposition towards any clotting factor disorder, all of this just immense plethora of complexity that exists. If someone's not being their champion in that, then they'll never know. I mean, where is that person going to find that out?
I will say this is one of my ongoing perpetual irritations with my colleagues. The number of times I have gone into a patient's room in the hospital and explained, hey, look, we need to have a conversation about whether you need to be on blood thinners for your AFib. Here's what AFib is. This is what's happening. This is why it tends to make you clot, and this is why it puts you at risk for stroke. And the blood thinners lower that risk, but then increase the risk of bleeding elsewhere, right? And both can be fatal, but if they are not fatal, a non-fatal stroke is worse than a non-fatal bleed, and that's why we tend to lean in that direction. And really giving that full explanation. The number of patients who have responded, no one ever told me that. No one ever explained what AFib was. And they've had it for like 10, 20 years.
Right.
Is a real indictment of the medical profession on some level. Like one of my favorite, this is a Richard Feynman quote, but or a version of it. And one of my physician mentors when I was in med school said, if you can't explain it to your grandmother, you don't understand it. And there's a lot of doctors that don't actually understand what they're doing and why. And so they can follow the algorithm and they understand it in medical terms, but if they were pushed to explain it to a patient without the medical background, I think they would often struggle. And then the question becomes, well, what are we doing here? Like that doctor means teacher, right? That's the Latin origin of the term. And so if we're not teaching, then what are we doing? But I mean, it's not just doctors' fault. I mean, like obviously it's the environment. You can't teach in 5 minutes. I mean, I think the average family practice visit is down to, I think it's down to 12 minutes or less,
It
right?
is. Yeah.
And so it's like, okay, well, what are you teaching in that time, right? Not much.
I mean, that's these are issues of great proportion. Is this an ethical discussion? Because at the risk of not treating an additional 10 patients in that day who would really benefit from a medical intervention, I don't know.
Believe me,
Not my area.
no. Believe me, I face that in my own practice, right? I mean, like the problem with concierge medicine as I'm doing it is, I spend an hour per patient every time, at a very very high level of depth, psychologically, philosophically, medically, scientifically, statistically. We talk about it all the way down to the as far as they want to go, right?
Right.
But I can only, I mean, my practice probably as it grows can only handle, personally, I could only handle a maximum of 100 patients, right? With some technological advances, maybe I can bump it to 150, whatever, right? But I'm not seeing the 2,500 to 3,000 that's the average for the average family physician who takes insurance. So what happens to all those other patients who are not under my care on some level? And so it's a trade-off between, look, are you going to get the best care for a few, or are you going to get a minimum level of care for a bunch? And you probably need a balance, to be totally honest, right? Because the best level care hopefully drives the middle forward. That's where all the advancements come from, right? But yeah, there is an ethical argument there, I think.
I mean, what happens to those patients. They go see someone else, or they
Sure.
get delegated to a mid-level provider, and pretty soon, wow, I don't want to say anything too hyperbolic, but a lot of the people you don't see are the ones who are going to end up taking medical adjuncts that you wouldn't prescribe.
Sure.
Um, and that's
And
just kind of how it goes.
yeah, I mean, I get that. I struggle, I guess, a little bit, and this is my own personality, right? I have a very hard time participating in something in which I'm not allowed to do my best. And in medicine, sometimes you have to. That's just the breaks, whatever. But I have a hard time when I go in and that's the plan. The plan is for me to not do my best, right? And so I used to work here in Austin, at the Seton system of hospitals, whatever. And, they would ask me to see 25, 28, 30 patients a day in the hospital. And I'm like, look, can I do it for a day? Sure, maybe, whatever. But I'm firing from the hip. I'm not reading articles. I'm not looking up what's the best thing. I'm not thinking at all. I'm just going off whatever I remember from the last time I saw this condition, right? And hoping that it hasn't changed, hoping that no new information has come out and it's still
Right.
the right thing to do, right? And yeah, I left the hospital every day not sure if I did everything I was supposed to do. Like I try to keep a checklist as I go through all these patients, but did I check everything? I don't know. Whereas when I'm seeing 15 patients in San Angelo, right? I double and triple check that list. And
Right.
everything, when I walk out of the hospital, I know everything has been done the way it was supposed to be done, right?
Right.
If I don't know something, or I haven't seen a condition in a while, I look it up. And if it turns out to be the same, great. If new information has come out, then I'm able to upgrade what I'm doing.
Right.
But but the plan in Austin was for me to do a shitty job, and that I have a really hard time participating in. Occasionally in San Angelo, it will be 25 patients, but it's occasionally. It's not. That's not the plan from the outset, right?
Right.
And so similarly with my own practice in River Rock, you know, I could not practice outpatient insurance medicine. I would quit medicine first because I just can't. And then that's how I console myself. It's not a choice between me seeing 100 patients and me seeing 2,500. It's a choice between me seeing 100 and zero. Like
Sure.
I would go do something else, right? If
Well,
I had
and
to
I
do with
think
insurance.
I think that that's why, I haven't been on a podcast or done an interview online in like a decade. I've scrubbed my social media. I'm just here, but this is something.
Welcome back into the world of.
Yeah, I know you pulled me. I feel like it's like a reverse Morpheus. You
Mm,
pulled me, you plugged me back into the matrix. Um, Very Agent Smith of you,
yes,
actually.
that's right.
Um,
That's
I feel that what you're doing, there's two ways I look at it. One, well, there's a couple ways, maybe three. I like you and I want you to do well, and I believe in what you're doing. But two, like everyone could benefit from at least listening to some of this.
sure.
In medicine especially, there is not one way to do anything.
Mm,
With my experience in medical device, I mean, you could take the same patient to five different doctors and get five different approaches.
sure.
Understanding the pros and cons, like I think that's worthwhile.
Sure.
And with surgery, it's so much more, especially like spinal stuff. Like this doctor wants to come in from the front of my body, this doctor wants to come in from the back.
Yeah.
With medicine, it's a little bit more complicated because it takes more understanding. It's no longer just a physical, observable thing. There's a lot of nuance, and different physicians have little idiosyncrasies about why they do certain things, but it takes a much less understanding of the world to understand, like, hey, this doctor wants to do this right here on my body. I can point to it. He's going to point to it.
It's structural. We have physical intuitions. We don't
Yeah.
necessarily have the same statistical intuitions, right? Although, actually, so this is another thing. So something I came across as I was kind of studying how to communicate with patients better is that people's statistical intuition is massively improved if you express things in terms of groups of people rather than percentages. So if I say if you had 100 people, one of them would have this, something in our brains pictures 100 people and then pictures
Right.
one, and in that context our statistical intuition is not bad. If I say 1%, it doesn't trigger that visualization for most people, and you end up with poor statistical intuition in the standard. But it's a simple change in communication style to get people with that vision in their head, and they reason better, just like they would structurally. Like if I show them, here's your spine, this is what I'm planning to do. Okay, I have physical intuition about that, right?
Right. No,
So again, these things should be taught. These things were not taught well in medical school or in is how to communicate statistics effectively.
I
But
can see that, but I mean, I still think that the average person, not a but, it's just in addition to the physician doing a good job of explaining the risk reward, there's just I feel like the the void in between the like the knowledge spectrum of what people who even had undergraduate or maybe even high school science versus people who don't understand, like that is a we don't give people enough credit on what they don't know, and we have a
mm,
tendency to give people too much credit on what they do know, and I think that has to come back to some of the consumer nature of medicine where it's at. You know, you can there needs to be some kind of exchange, right? Like patients feel like if you're to go and see a physician and you don't leave with anything other than knowledge, you got gypped. You know, I didn't get
mm,
a prescription. I didn't get, you know, a digital rectal exam. He obviously doesn't care. Like,
right, right.
I feel no better than I did when I went in there. That's not
Here,
very appealing.
sure.
You know,
Here's a really so we were talking about controversial opinions. Here's one of my additional controversial. There's a great study where they brought research subjects in to a room, and they had a wheel, like a wheel of fortune kind of thing. They would spin the wheel, and it was preset, right? It was a rigged thing. In half the groups that they brought in, it would land on the number 14, and in the other half it would land on like 76 or something like that, right? And the researcher said this number has nothing to do with anything. It landed on 14, but I'm telling you now, it has nothing to do with anything. Now, the question is, what percentage of African nations are member states of the UN, right? And in the group where it landed on 14, the average answer was 25, and there was a bell curve around that. And when it landed on 76 or whatever it was, the average answer was 64 with a bell curve around that, right? Is even when told that it was irrelevant, people anchored on the information. You can't unknow things. And so, from a medical standpoint, we should be very careful about what information we gain. Are we gaining information that is directed at something that's going to help this patient? Or are we just distracting ourselves with potentially irrelevant information and ending up harming the patient by gaining, I mean, again, and so where this goes actually is I'm actually somewhat against the routine physical exam. Like, if you listen to everybody's heart all the time, you're going to pick up on a lot of irrelevant murmurs. And I don't know that we're helping people by doing that.
see, this will be a different podcast that we'll talk about screening, genetic testing, all of
Sure,
that.
that's a whole different ball game. But for that reason, I tend to like my exams for patients are deliberately fairly minimal and directed. Now, if you come in, you say, "Hey, I'm having vertigo," you're going to get a very complete neurologic exam, right? More complete than the average family physician even knows how to do, because I spent a lot of time with neurologists, with them teaching me the best way to do those exams. Um, Same for cardiac. Like if you come in and you say, "Yeah, I've got chest pain or I've got shortness of breath or whatever," you're going to get a very, very complete cardiac exam, right? I have an ultrasound, I have an echo that I can do in the office. So I'm actually going to look at it. I'm going to listen to it, all the things. But if you just come in and say, "Hey, I'm, whatever, not working out and I've gained weight, well, I'm not going to listen to your heart. Like, that's a waste of both of our time and could potentially lead us astray. And
Sure.
so, let's talk about why you're not losing weight. Why aren't you motivated to be in the gym? X, Y, and Z. Um, and so, I mean, and I do get a fair bit of cardiac data from doing VO2 maxes on everybody. So that's also, I do rely a little bit on the fact that, like, I actually am doing sort of the most sensitive screening test possible for cardiac disease. But, but yeah, it's an interesting stance that I think in medicine is not as popular. I think, it's always gain as much information always as possible. And it's like, I don't know.
There's two things I feel about that. One, I think for it kind of depends where that information's coming from. So for me, being, just this lowly plebeian when it comes to medicine, everything that I gain still is very much fundamental, like biochem, organic, how these molecules fit, and I kind of go from there. So the more I understand, I feel like that's probably better. When you're talking about medicine and medical knowledge and how that's coming, I can't imagine like you would have to protect yourself as a physician because there's a lot of information. This is the age of misinformation.
Mm,
And I don't think that medicine's exempt from that in any way, shape, or form. Treat like listening, the physical exam. I'm not a doctor. I can't speak to all of that. I know from my time, the couple thousand hours I've spent in an operating room, you have to treat the symptom. You cannot treat imaging.
yep.
There are people walking around right now with, chunks of disc rammed into a foramen, touching their toes, doing cartwheels, and would never know the difference. That's not
Yep.
the patient that needs, a 5-level fusion.
Yep.
But whenever a patient comes in with foot drop or terrible radicular pain, and then sometimes you'll even look at it and they have their imaging looks good.
Yep.
So what are you supposed to do?
Yep.
Where do we go from there? But you would never cut and then try to rationalize from that direction. So you would in medicine I do see that a lot where people, they come in and they came there because they have a sore throat and they leave there and they're wearing a monitor and everything else and
Yep.
really they just said sore throat because they've been out promiscuously that weekend. They knew they've got some azithromycin out of the deal. They'd probably be fine. Like that's
Yep.
another whole thing that y'all have to deal
That's a
with,
whole
which
different
I
thing.
can't imagine is what information the patient's willing to share with you versus the truth.
Mm.
I think that complicates your situation.
So again, this is again one of the benefits of having a tremendous amount of time, right? Like, if I sit down with my patient, minimum 1 hour per visit. The first few visits often stretch to 2 or 3 hours. Like, it's a lot of time. So the rapport, the sense of safety, the sense of this person knows me. I'm not gonna lose their respect. They're not gonna judge me. I'm fairly open with patients, deliberately so as a choice. I give examples from my own life. I give I share those things to express my flaws so that there is safety in the notion of sharing when the time comes that, hey, this is how I went off the rails. I need help, right?
Right.
And that's a deliberate choice, which I think you can argue in different ways, but that's kind of how I've bent it.
Sure.
Meaning I'd rather not appear all knowing and all powerful, though that has advantages, which actually I may take it in that direction in a second. But the reason I've chosen to, and I say I don't know a lot, right? Which I'm like, yeah, I don't know that exact percentage. I could try and look it up for you, and if you want me to, I will, and I can give it my best shot. But off the top of my head, if I don't know, I just say I don't know. Part of which is building trust, because to me,
Right.
trust is the one thing you can't fuck with. Like, either someone trusts you or they don't, and once you lose it, it's hard to get back.
Big time. 100%. I totally agree on that. I mean, not even in sales and working in industry, it is so much better to say like, "Hey, I'll get back to you on that." No, I
Mm-hmm.
don't know, than to fire something off because, and again, you always kind of give people the benefit of the doubt. I assume that if someone asks me a question, especially a physician, that they know the answer and they just want to know if I'm. So I
I see.
always, I
Yeah, yeah,
always
yeah.
speak to what I have
Sure,
knowledge on, and then always divert when I don't.
sure.
And then you just, can't BS a BSer, all that kind of stuff.
Right,
And
right. Well, I mean, I guess so. To your point, then when patients come to me and they're like, "Yeah, you know what? I was in Vegas and whatever
things.
things happen, and I need azithromycin because I think I have gonorrhea in my throat." They're gonna tell me why they need azithromycin, right? I'm not gonna get a fudge. I hope I've done as much as I can to not get a fudged set of reasoning there.
The a issue with the age that we're in is that that patient came to you, and I know they do, and they said, "Hey, I think I need azithromycin." They can't tell you what a penicillin ring is. They wouldn't know about material science, but they managed to get online and plug in enough and say, like, "Hey, if
Sure.
I do these sexual acts here, am I exposed to this?" And they can come to you and say, "I need azithromycin," not knowing what azithromycin is, not knowing what, the mechanisms of action for an antibiotic. So I think that physicians like yourself, it's the only era where people come to you and tell you how to do your job as a physician, what you are need, what you should prescribe, what they want to see, and
And
I can't imagine that.
see, the thing is, I love that. Like, and the reason is that when you have time to build a rapport, then it is a true partnership. And all they're saying is, I'm invested in this, and I did research because I care, and I am also trying to find the answer. And they're I don't take it as them trying to tell me what to do. They're just trying to get to the right answer. We're both trying to get to the right answer. And so my ego's not in that. I'm just like, how'd you get echoey
Did I get echoey?
for a second? Yeah. Um, but yeah, my ego's not in that. I mean, I just view it we're both trying to find the right answer. And so, which you can only do when you have time and space to really build a personal relationship with the patient.
You're just too nice of a guy. I don't
I
know
don't
what
know
to
about
tell
that.
you.
I don't
I
know about
just
that.
think,
I
yeah.
tell patients no all the time. I'm just like, that's a terrible idea. I believe
Well,
I offended a patient recently by saying that his plan was foolish, but that was he and I had to have a longer discussion from there. But and whatever, and I told him, I was like, look, it's he was like, yeah, I don't want to hear that from you, and this, and I was like, look, it's my job to tell you if I think you're doing something that will harm you. Like, I'm not gonna. You can proceed. I am a very autonomy promoting kind of person. I fully think if you disagree with me, you should do as you see fit. But it's my job to tell you my opinion. That's literally the job description.
right.
Is from everything I know, this is a bad idea.
Sure.
If you go ahead with it, I'll help you deal with whatever falls out.
Yeah.
But same for testosterone. I mean, I've got patients who are doing testosterone, and I'm like, look, I think from a longevity standpoint, this is a bad idea. If you want to go ahead, go ahead. We'll figure it we'll
Right.
figure it out from there, right? Um,
Yeah.
and yeah, I think that team partnership that still respects autonomy, respects their right to disagree, and doesn't take it as an ego hit when they disagree, right? I'm like,
I wonder if there's like some kind of confidence or solidarity, like the fact that you're not offended, because I'm offended by it, and we've had this
yeah,
conversation so often. I'm
yeah, yeah,
offended.
yeah.
Everyone, like it's the era of like you joined a Facebook group, so now you're a material expert, or you're an economist, or you're a scientist because this drug is bad. The whole overarching theme of what we
So
just came out of pandemic wise.
I guess there's a couple of things that I keep in my mind that I came across fairly early in my medical training. So the book Complications by Atul Gawande, as well as all of his other books. He's a great writer, medical writer. But he talks about how anesthesia in the 70s and 80s was much higher risk than it is today because
Right.
the error rate was way higher. Like anesthesiologists made way more mistakes. And, you know, that didn't become safer because anesthesiologists didn't care then, and they do now, or, you know, whatever. It became because an engineer was walking through some of the anesthesia suites and noticed that all the machines from different manufacturers had different dials that turned in different directions. And so higher dose for one machine was clockwise and was counterclockwise on a different machine. And there was no standardization whatsoever. And so the solution was from an outsider, right? That, hey, this is how you improve the safety of anesthesia, is change the machines to be standardized, right?
Wow.
And so the the notion that a non-expert can find the right solution is always in my mind. I mean, it's always like there's a danger in becoming an expert. Is you close your mind. I mean, whatever. It's the Buddhist philosophy, right? In the beginner's mind, there are many possibilities. In the expert's mind, there are few, right?
Right.
And so trying to find the balance there between, look, this is what I think we know. This is why I think we know this. And then maybe there's an outside solution that's the relativity to Newton's, theory. Maybe it needs to be turned over. Maybe we're missing something. And so, yeah, people's right to explore has to be respected because there's no guarantee we've got it right in a final way. And often the insight about where we're getting it wrong comes from somebody who's not steeped in the system, right? And
Sure.
so I engage in argumentation or in debate or in discussion with patients, teaching from what I know, where I know it from, why I think this is the case, and I try to be as honest as possible about where our knowledge is shaky. Like we think it's this because of this, and this, but there are other possible interpretations, right?
Right.
And so, yeah, I try to engage with patients that way and respect their right to disagree and to say, hey, I'm going to go this direction, and I don't know, maybe that is better. Like I can say there's no evidence for that. I can say from what we know that's unlikely to be the best path, but I can't promise that in most cases. I can't say definitively that's not going to work out.
I understand that.
And so,
Yeah, I mean that's again, you have a really
I mean,
I just
it's that line from the Lord of the Rings, right? It's just die in what way seems good to you. It's just
no,
everybody
don't
has
bring
that right.
Tolkien into this. Don't bring Tolkien into this. I understand that. I just still we have a little bit of a we see it a little differently. I would prefer a critique or a question from someone that I at least know they're pursuing some form of greatness and not greatness, but like they have a level of understanding that makes it where even their inquisitive nature isn't just contrary. Like nowadays, people would poke holes in an argument just because, and there's always gonna be contrary people. So
Sure.
um,
I
I
mean,
don't
you see
know.
that even in the testosterone video and hopefully in my other videos, I try to distinguish between when I'm talking from evidence and when I'm storytelling, right?
Right.
Like this is the story that makes sense to me, but that's storytelling. And here's the actual evidence that I'm basing this story on, or that any story that we tell needs to account for this set of evidence, right?
So something to that, another person that I showed the video to immediately was like, some of that data is pretty old, and I was like, and I was like, did you have any data to the contrary? And there, of course, no.
Right.
So how do you feel about that? Pushback
Well,
from
yeah. I mean, I think that's valid. I think a number of things are valid about it. The problem is that it's like looking at the Nazi studies, right? Or looking at like studies that were done on prisoners. A lot of the RDAs, like that the FDA uses, come from studies in like the 1900s that were done on prisoners, like against their will. Like they would starve them. Like the what is the minimum daily requirement for protein? Well, let's starve people, and then gradually and measure their urine and gradually feed them more and more protein until the nitrogen balance is achieved, and that's the minimum, right? And we did that on prisoners in this country, and that's how we found that information. Now, you can never do that again.
Right.
So there will never be an update on that study. That's it. That's the end. And so similarly for like the castration studies, like you're never going to have a systemic practice of castrating young boys and see what happens, right? So it's going to be old because we're not going to do that again. So
Right.
yeah, it's a fair complaint, but it's also unfixable.
Right. So again, does that not feel like did that whenever someone's just debunking you for the sake of being contrary? Because
No, I
they
love that.
see, you're just
That's
I don't know.
that's
I just
great. I
think
mean,
I
yeah,
take
you
greater
should. That's
personal
how
offense.
that's how we get to truth. Like that's how we is by debating back and forth and arguing around and like seeing where the flaws are.
I threw down the gauntlet. I was trying to defend your honor. I said, let's
Yeah,
do this in the old way. I have a horse and a large wooden pole. I'll see you. I'll see you on the
that's right.
battlefield.
That's right. That's good. That's good. That's why I need you around. I'm just too neutral on these things. I'm like, yeah,
Yeah.
let's think about that.
That's what
What
the
what
philosopher
is this?
comes out. And,
It is, and actually that's kind of one of the things is that like from my philosophy training, you know, one of the things that really stuck in my head was the that it is the ad hominem attack is a logical fallacy. So if I make an argument and you say, well, Hitler made the same argument, I'm like, cool, but you haven't addressed the argument,
right.
right? That's irrelevant. And so if you're like, if this person making an argument and you're like, well, who are you? You're not educated. Well, you haven't addressed true, but you haven't addressed the argument. And if it's a bad argument, you should be able to address it. So there's no reason to bring that background in, right? Now again, I come from a perspective of being willing to take time. So if the person's coming from an uneducated background or a medically non-educated background, I may have the explanation may be long because I have to bring them up to date on background data, right?
Right.
But I can walk them all the way through the thought process and be like, okay, here's why that argument doesn't work. Let's start with the cell, right? And so, you know,
Glycoproteins. The answer starts glycoproteins.
correct. And so, I mean, I have, you know, whatever, a joke among my friends and many ex-girlfriends who have hated this is that, like, I get this from my father, too, is the joke is I begin every explanation with the parting of the Red Sea. And so it's like, let's start here, and then we'll move forward from there, right? And so it does tend to be that way a little bit, but this is partly why, is because it's like, well, I'm not going to write you off just because of your lack of background here. I will fix the lack of background and then we can have a conversation, right? But we both have to have the patience for that. And
Right.
that's the trade-off.
Well, and for my own, not to that I have to save face, but like I, of course, and like the reason I'm on this podcast, like I'm not a subject matter in anything,
Yeah,
not even remotely. It doesn't take away from any insight that I have,
that's right.
and I feel like that's like almost like interviewing 101 is truly like you can learn something from anyone. And it doesn't always have to be from maybe their sphere of what we consider expertise.
It's a great
Because people,
example.
go
It's a great
ahead.
example of this. Elon Musk was giving an interview on one of the SpaceX rockets to some kid, like some random YouTube kid, and he was talking about one of the fuel system or one of the problems they were having with the fuel system, and the kid was just like, oh, like why don't you do it the same way as you did the other, like you said the other one was a solid state fuel, why aren't you using a solid state fuel here, and then you wouldn't have to worry about leaks, right? And he redid the rocket, like he was like, oh, you're right, that would fix the problem, cool. And just like random, not an expert at all, was just like, oh, I don't know, like you said you did it that way over here, why don't you do it that way over here, like,
Sure.
and right. And so just that willingness to be like, yeah, I just want the answer, I don't care where it comes from, right?
Right.
And
Well, I
so,
mean,
yeah.
I feel like that's super apparent, especially whenever I first started coming into ORs as a rep. You would see things like so much. There's navigation and fluoro and all these things have advanced, but some of the fundamentals are like literally just pieces of metal. Exaggerated cutlery from your kitchen,
Yeah.
and some of these
Yeah.
guys, like names that we'll remember forever, was the difference between having, a straight probe versus a slightly curved probe.
Mm-hmm.
And now you get your name. They're immortal. That's
Yep.
immortal. A piece of metal from here,
Mm-hmm.
nothing. Here, immortal.
Yeah.
And
Yeah. Yeah. Yeah.
but it's everyone's gonna know what a linky probe is from
Mm-hmm.
here on out, and
Yep.
it's sometimes it's we get lost in the weeds, and I would say experts get lost in the weeds. It's
Totally.
funny, your Buddhist quote, I didn't know if that was a Buddhist quote or if that was Greg House. It had a little bit of that too.
Sure. Sure.
And not everything has to be 0.0001% to be the truth. Sometimes the truth is large scale,
Yeah.
and
Yeah. Yeah.
abundant.
Yeah.
But again, that was my thought at the very beginning, or towards the beginning of this podcast, was we misidentify correctness with complexity, and
Yes.
things are simple. Things can be much
Many
more simple.
things. Yep. The core of them often is, and it's interesting. This is something I talk about with one of my best friends here. Like the nature of complexity theory, and I don't know if you're familiar with he's in computing, but the notion of computational irreducibility, and or are you familiar with the game of life?
Another game of life.
Yeah, and so that idea is that from very simple rules, you can get an infinite amount of emergent complexity.
Right.
And so it actually doesn't take complexity to explain complexity. You can often explain complexity with simplicity, and sometimes you can find what's called reducible simplicity, where you can predict the end outcome. And sometimes, even though you find a simple answer, it does not help you predict at all, and that's irreducible complexity, right? And
Sure.
that's one of those weird things where it's like, even though we know the simple explanation, it still doesn't help us.
Well, and I feel like I watched one of your videos and you were talking about how, you were really inclined naturally, like an innate understanding of mathematics, but it seemed too simple compared to medicine.
Oh
There's a
yeah,
derivation here, you can integrate this, like here's
sure.
the proof. And that's so funny to me because it's the opposite. It's like, oh, medicine, when's the last time you were, calculating thermal expansion, or flow
Sure.
rate on a patient. However, just I feel like that goes in hand with just what you said. So
Yeah, yeah,
that is interesting.
yeah. I wanted to loop back around the other. So this is something I've been wrestling with, and I think this might be a great exchange here. One of the we've kind of done a great job of kind of explaining my approach on some of these things. So the downside of my approach, as it has somewhat come out, is that I do not come across as inspiring. And so I motivate less behavior change in the broader group of people, and only a certain segment who are able to be motivated by information, by sort of like very precise understanding, and they generate motivation on their own from a precise understanding. Whereas most people's motivational system is more emotionally driven and inspirational, and I don't hit that very well.
Oof, man, this is a big one.
Mm-hmm.
First off, like you are just better than the rest of us because that seems like your. I hate to call it this, but like it's your greatest shortcoming,
Yeah,
right? Like, as
for
far as
sure.
this mission is considered.
Yep.
I would never volunteer my greatest shortcoming. I would keep that hidden and suppressed.
That's
Uh, I don't know, Zane. It's like, do you need better graphics? Does there need to be neon involved? Do you need something controversial? Should we clickbait it in a way where it's like, Zane cries like testosterone? Cut your balls off. I
that's
thought that would be a real,
sure.
but to are we talking about trying to get people to invest in your vision, like to?
That's a big part of it. That is a big part of it. I think the other framing is because my mind works in probabilities and I speak in probabilities. I rarely talk about like, hey, if you actually get your VO2 max up and you get your strength up, you're gonna feel great, right? I don't say that because I'm like, well, you might not. You might still feel like Shrek. Like you'll live longer, but I have no guarantees on this, right? And I don't know. I think my mind rebels against the notion of certainty in general, which is what allows me to pursue these things this way. But it also means I never speak with that uh, inspirational certainty of this will
Okay,
be awesome.
this is funny. One, I have a lawyer who wants to come on, so
Okay.
that was my second question. Will be like, is there liability if you say you will get better? I don't know that.
Yes, there is. Although, again, you can kind of hedge. There's a lot of. Yeah, you can say, "I think you'll feel better." Like,
So that's what I
right?
was
That's
like.
an
Even
opinion, right?
can
But
you,
emotionally, it would communicate the same, and I still don't.
dude? I wouldn't even tell you. You need to get a little dirtier. Like you need to like not be
Maybe.
as transparent. Like you
Yeah,
should take
maybe. I mean,
some of the honesty. What about could? Could is a good word. Like, you know, hello,
yeah.
patient. Like, if you get your VO2 max up, you could very well feel great. This time in 2 weeks, you could lose weight. You could. Could is great. I use
Could
could
that
all the time.
I could use could. I could.
Right.
That's yeah.
And could is wonderful. It's really good. Um, I, I think, I feel like you are progressing in all areas of this. I'm not as involved in like the financial side of the business and getting to know that area and growing the practice, but your vision has grown. I feel like you've fleshed out your vision well. I think that these podcasts, the video content, I think that is a great way to attract more people. Identifying a population is going to be, just like you said, like everything from your little analysis of who really clings to your ideals, your ideology as far as medicine goes, like it's a smaller group. So how do you
It's also
increase that?
well, and it's also a tough message. So let's also frame that, right? Like at the core of, so this is looping all the way to the beginning and kind of maybe pulling a lot of concepts in. If your VO2 max is in the 99th percentile, your strength is in the 99th percentile, you have a full docket of social connections, you don't smoke, minimize drinking, aren't, you know, significantly obese. Okay, ideally you get your blood pressure under control, though I have a hard time imagining many people in the 99th percentile of VO2 max have high blood pressure to that degree. Maybe cholesterol, right? Maybe that a lot of debate on that. I don't think so, but many people do. Even if you throw that in just for funsies, um, you've reached the end of the road of longevity. This is the big harsh message I have is that that's it. You're living as long as you're going to live at that point. Now you need to turn your attention to what you're doing with the time you have and what
You
will
should
make it worthwhile.
you should clip that. That should be maybe the thumb. Like this is what we know. And this is the end. And what you said,
Yep.
that's a couple sentences, and it's
Yep.
very, very, very little.
The
Blood
problem
pressure, maybe cholesterol. So everything else is going to have to be approached differently.
the big thing is okay, a lot of my patients probably are at the point where they're going to live as long as they're going to live and they're still looking for the, is it red light or is it this supplement or is it rapamycin or is it whatever, right? Or testosterone or whatever the deal is. And I'm like, nah, it's not any of that. You're maxed out. And the harsh message is you can't push that any further than you've pushed it. And so you're wasting your time trying to push something that won't be pushed instead of using that time to enhance the meaning of your life and the degree and depth of the time that you have. And that's why my content's probably not popular because at the core, I'm saying that the dream itself is flawed of living that much longer. You can maximize it to the degree of your genetics and your health span, but
So this circles back a little bit to like the consumer nature of where we're at. People will have to augment their paradigm because you effectively like if your ticket has been stamped and
mhm.
your time is set, which are we saying that's what the case is? That for the majority of people, we're talking very about marginal
Oh,
reductions in
no, no,
mortality.
no, 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 no. I guess that's what I'm saying is that like for your average person going from a mid-level or low VO2 max to 95th, 99th percentile, you'll get huge gains in longevity, right? If you go from a very lonely, isolated person to a very connected person, you'll get significant gains in mortality. But once
Right.
you've done that, there's no more to do. Once you can, hit certain squat metrics, whatever we think they are. I'm still kind of calculating those, but once you're in the 99th percentile, you don't get more longevity out of more. And
Sure.
so, hitting your max is not. I think most people are not at their maximum longevity in the population, but getting there also isn't that difficult. If you dedicated yourself for a couple of years, you could get there, and then you'd be done, and that would be the most you could do. Like, and I think that's the hard message for a lot of people is in my patient population. So that's the other thing. A lot of my patients are very healthy by standard metrics, right? And they're looking for more. They're looking for like the Brian Johnsons of the world, right? Is like, well, I want to X Y Z. I'm like
I want to be
that.
18 years old.
Yeah,
The complete, like, just absolute red herring tangent is if you use a metric of leg press for your health, of how you now have a single leg press of like an 18-year-old, you've lost all credibility as a man. Like, if you're the guy who talks about how much he can pull on like a weight, like it's either squat, deadlift, or bench press. Those are the only marketable things people care about if you lift. If you're talking about your whatever grade of single leg pistol squat ninjutsu you came up with, you've now discredited yourself. He could literally come out with a pill tomorrow, and I wouldn't buy it because I'm like, oh yeah, that guy talks about doing single leg press and brags about it for billions of people on the internet. Sorry, that was a personal thing I had to clear. But yeah, the
So,
reduction in
so you're saying you
a
you you really like single leg press as an exercise? That's
I just think that it is so like I think that could actually be something to build upon for people's other understanding. It's like, hey, these markers are as the same level of statistically supported metric as single leg presses for longevity.
right.
Like that would be something. Like, you know, first
So,
off, whatever biological markers he's using to say he's got, 18-year-old gonads, that's weird. And I want to know.
right,
I want to know how he came up with that.
sure. I will say so. Again, continuing down this tangent, which is interesting to some degree, the longevity studies that have been done are interestingly problematic for translation into the real world. So, a lot of them have done. The ones I've been looking at are on leg extension strength, but it was measured with a dynamometer. Like they literally hooked a metal device above and below the knee and measured the maximum force in like rotational newtons that could be produced at the knee. And I'm like, cool, but how does that translate into a squat? Like I don't know. Like and so I'm actually doing a bit of research with a physical therapist on trying to figure out what that would translate into. But they didn't do back squat as the measurement. They did a very physics based maximum force at
Right.
knee, which is kind of cool on one level, and I get how it's more objective and more whatever, but it also leaves us with a translation problem into practice.
Not so. Also, one thing that has to like we haven't about directly is so whatever these metrics are, and whatever you could change in your life to increase your longevity, like a reduction in cholesterol, reduction in blood pressure, there is a diminishing return on investment at some point because if you get your quads so strong that you get a patellar tendon rupture from the amount of exertion,
Sure.
and I don't think I think that's not well understood about some of these adjuncts. It's like, you know, cholesterol under 200, great. Cholesterol under 50, probably dead. Like,
Yep.
things like this.
Yep. The notion of the U-shaped or J-shaped curve is not promoted enough.
No,
Even cardiovascular exercise, like after 75 mets per week plus, you do see a reduction in longevity, right? So yeah, cardiovascular exercise is great for you up to a point, and then it plateaus, and the plateau is pretty long, and then it declines. And
right.
the decline point is like 75 mets per week. The plateau point is pretty well before that. And so now that's Olympic level training. So for
Sure.
exercise, it's pretty far out there, but it exists, and it's important to know that more is not blindly linearly better.
Right. Yeah. I mean, absolutely. Like well, look at I think we talked about this last time we had dinner, was the word, the CrossFit buzzword, rhabdo.
Yeah,
Like
yeah.
rhabdo didn't exist in the world until like 2003. Like it just emerged. It was like, and I
And
can't,
the
like, I saw it.
awareness of it emerged. Yes.
Oh, no, no, it didn't even exist. Like, and then all of a sudden, you know, AMRAP, uh,
Sure.
front squats, rich froning, rhabdo. That's all there is to it.
Yeah.
But it's just, that's amazing to me. I mean, I don't know when the first like documented case of rhabdo was, but I'm pretty sure it was, before the 21st century. But that's what people hold on to, and
Well, I mean,
the
we learned
popularity,
it. We learned it in very different contexts, right? Pre CrossFit in med, because I was in med school, and we learned rhabdo in the context of crush injuries.
right?
The elderly who had been found down for multiple days and had been on a muscle, kind of like compressing it,
Right.
right? So or alcoholics or whatever. Like there were other scenarios where rhabdo popped up, and then exercise induced rhabdo was not something we learned. That was something we saw after the fact.
Well, I mean, I feel like that's
I'm sure it existed before. I'm sure some bodybuilder somewhere had previously done it, but it wasn't one of the
sure.
major causes we learned in med school.
Right.
Right.
And I mean, I know it was documented and it was a thing, but what I'm trying to convey is the idea that these were some of the fittest people in the world. Like that was, and that this is something that happened more often. So, like, at what point do you draw a line? Like, at what point do you say, you know, and that's the thing that's so interesting is I feel like you're redefining fitness, but whenever you talk about fitness, and half of the fitness people that you see on the internet are dangerously ill. I mean, some of these people, if you put on 100 pounds of the best contractile tissue you can possibly find, that is not good for you. Like,
Yep.
your body's not designed to carry that. And that's another thing, that there are deceptive metrics, can be deceptive. One of the best points you've ever made is, like, for instance, if you were 250 pounds yourself at 8% body fat, besides the fact that you would just be a sight to behold, like just a muscular mountain. And there's also, another little aside. I would love to see that. That's why I love looking at these things. I love going to the zoo. I love all of these extremes, like monster truck rallies. And that is a huge appeal of some of this. But if you were 250 pounds and you put yourself, a colleague of yours put yourself on enough beta blockers that you were sitting at 120 over 80, you are not healthy. That is
Sure.
not a natural, that is not the equivalent of you being 180 pounds at 120 over 80.
Right.
And I think your specific example was like A1C. You could augment how the machine read your blood levels, but that is not the same as you controlling your A1C
Sure.
naturally. So people think that that doesn't cut both ways. So say whatever you're trying to increase your metrics to, or like, for instance, taking testosterone to get stronger. Like, nothing in this world, I mean, you know,
It's
everything
the
has equal and opposite reaction, right? Like,
it's the
something
hand
has to.
grip thing as well, right? It's like, okay, we it was originally a metric of strength overall, because yeah, if you can deadlift 300 pounds, well, your grip strength has to be able to grip it. So There's some correlation there, and they just kind of used it. That's very different than saying, well, I'm just going to only work out my grip. I'm not going to work out anything else, but I'll be able to grip, I'll be able to squeeze this incredibly hard while the rest of me is completely, atrophied. And you've gamed the test there. And whatever. I think people get it when you say, okay, yeah, hair follicle transplant isn't going to help, or A1C you can reduce by donating blood, right? But that's not gonna change anything because your blood sugar is still running high all the time. You just gamed the test, right? What people don't seem to get for whatever reason is if I put out a study and say, look, your vitamin C, high dose vitamin C supplementation lowers A1C. Everybody's going to go out and start supplementing vitamin C, even though the reason is just because it screws with the lab equipment. Vitamin C in the bloodstream at that level screws with the ability of the lab to detect the A1C. It doesn't change your sugars.
100%. So that's a whole idea in itself. What are you actually doing to elicit a certain change? And is that change deleterious? I would say that whatever amount of, kidney stones or whatever might be as a result of taking that much ascorbic acid would be high. But the more, like, I don't want to say asinine, a confounding part of this to me is that especially with testosterone supplementation, it's one of the few things where people are like, by the way, we need you to go get blood every 6 weeks. Let's just put it right there. You need to go get blood every 6 weeks. If you tell me anything else in my life, like, hey, we fixed your car, you just have to go, like, let a little oil out. Hey, like, you have to make this payment, but you have to go make a donation to this specific organization. Otherwise, you're going to die. You're going to lose your house, you're going to lose your relationship. I am not some medical guru, but it's offensive to me if you were to tell me to do something and then I have to go bleed, otherwise something bad's going to happen. Like, that's pretty archaic. That's right up there with some bloodletting, and I feel like they were actually more well-intentioned than half the people these days.
I mean, I don't know. I mean, but side note, there's some indication that blood donation, regular blood donation, for men especially, seems to have longevity benefits. But that's a.
I'm gonna go ahead and just speak with a complete just autonomy here. There is no evidence in the known world that says if I ramp up your RBC production to the point of you having some horrible cardiovascular incident, that if you don't go and let a little steam off, that it's a good idea. Y'all can come after me directly for that one.
And that's but that kind of gets actually to the point we were talking about. Is that, like, those are different statements, right? Is like, hey, donating blood regularly may may increase your red cell turnover. You have fresher blood because you're getting rid of some, making new, et cetera, et cetera. That may reduce the amount of, iron free radicals, whatever, who knows how, but there may be some longevity benefit. Versus, hey, I'm going to give you this drug to where if you don't go donate, you will rapidly increase the rate at which you have a cardiovascular event. Those are very different concepts.
Right. Sure. I don't know enough about it. I would say, I don't even want to speak on that. Rapid, blood cell, RBC turnover from exercise. Like, I'm sure that the more active you are, the more your blood turns over. That makes sense to me. I don't know. I can't speak to that. Versus, like, just sitting and watching something. Again, a big part of it is what are you trying to elicit? And so which metric are you trying to improve? How do you improve it? And I think that's twofold with testosterone, because a big part of what you and I have been talking about and what you've positioned in your videos is that not only does that level maybe not correspond to longevity, the means at which you change that level almost certainly are dicey.
Yep.
And that could be like, that could be the answer to this video. That could be our whole Discord right there.
That's probably it right there.
but that's a huge undertaking. I mean, that's a huge amount of understanding. Like it's taken me months. I fell asleep watching your video last night. You know,
That's a bit
I
extreme.
it's
That's
well, I wanted to, and it's all about, and then a huge part is like the concessions we make for our lives. I think that if you're a competitive bodybuilder, would I think it's the best for you physically to do that? No. Do I understand that everyone on that stage is a walking chemical experiment? 100%.
sure.
Now, a lot of those people, like you said earlier, like a lot of them think they're making an informed decision, like they have informed consent on what they're doing. From a lot of the interviews and what I've read, a couple books, papers, talking to some of the older generation of bodybuilders, there is some regret, and unfortunately, there's a lot of fear, and that's really sad for me because there is an empathetic part of this. Like no different than the people who abstain from doing from certain things because of like a fear of needles or whatever it might be. Imagine that because our narratives can change in 20 years. Like this
Hmm.
conversation on testosterone, you and I hope will be the standard of
Sure.
education and what I'll have my legacy as one of the first sit-in interviewees.
There you
but
go.
imagine if you're someone our age, or especially like I watched a video last night of a 17-year-old who started his performance enhancing drug protocol to become a young bodybuilder. Imagine if it's like everything you did is setting you up for disaster. You've
Mm.
taken years off of your life. Like some of this damage is irreversible. That's got to be so heavy. I can't imagine what that's like carrying that weight around.
Yeah.
And people talk about, smoking, and you stop smoking and you can make huge improvements.
Hmm.
Well, I mean, if you've occluded 80% of a vessel in your chest, how much improvement can you make by stopping? Like, I don't know,
I don't
but
know
I
either.
know that if I was going to be most empathetic, it would be towards those people who
Sure.
made uninformed decisions and now have very real consequences.
Sure.
One of my favorite bodybuilders drowned in a pool from having a cardiac incident, falling into the pool and then drowned to death. I mean,
Jesus.
there are bodybuilders in their 20s and 30s dropping dead every year
Yep.
from, and what it's they have incredible muscle mass.
Sure.
Their blood pressure's managed,
Sure.
however, and for some reason they all end up dead. And
And I get that's gets into the frustration to some degree I have with even like people like Andrew Huberman, who will say, "Oh, this Tongkat Ali supplement will increase your testosterone by this much or X Y Z," and it's like, I don't know, man. I mean, maybe it doesn't do the same level of damage as somebody who is injecting testosterone, obviously, but are you really is this advice you're giving shortening people's lives, and to what degree are you I mean, it's funny because like we talked about how I'm not super inspirational. Maybe that's part of my worry is like, let me present information, let me not super inspire people. Like,
right,
you think about what you want to do and what's important to you in these trade-offs, because there are always trade-offs, and
sure,
people like Andrew Huberman get famous because they are very inspiring, they're very dogmatic. Is do this, testosterone's great, you'll have muscle mass, you'll get muscle mass, and muscle mass is associated with longevity, and so okay, it sounds great. It's just it turns out not to be true, but where's the responsibility then, right?
well, I mean, and you can steer what I've the last few months. Really, you can steer a medical conversation and a scientific conversation however you want. You can really pick and choose data points in a way that I didn't understand that you could. I thought science was kind of like the rigid structure to adhere to, and I think in its purest form it is. But some of these studies, like I talked to you last time we got together, and I had read some studies that have been cited in a different article that was talking about longevity and testosterone as an adjunct for longevity. And then I went through and read their actual studies, and they had cherry picked some of the most obscure details of those studies. Well, like
Yeah,
5 years ago, I would have just read that and be like, oh, peer reviewed. Here's some, boom, done,
totally.
believed. Like, and now,
One of my favorites is in non scientific scientific journalism, right? You'll read one of these articles and it'll be like, as we know, X, Y, some claim, and then there'll be a list of citations, like footnotes, right?
right.
Click those links sometime, right?
Yes.
Often it literally says the exact opposite
That's,
of what
yep.
it's like one of those things, but they just trust that nobody's actually going to reference the citation or the citation is irrelevant or didn't even talk about that or whatever the deal is. But it makes it seem like, oh, this is a well supported statement. There's 4 citations to this idea, right? But
Well, I mean, and
it's just
especially in like the modern, so a lot of these people using performance enhancing drugs, testosterone specifically, they're some of this stuff on the compounds they're using like haven't left like rat studies, and it is
right.
referenced as 100% fact, and then the rest of
Yep.
it is completely anecdotal.
Yep.
And there are a couple guys who are so knowledgeable in the vernacular, much more than I could even possibly imagine right now. From estradiol levels, like follicle stimulating hormone, like, and all of a sudden I'm like, man, this reminds me of metabolism and like molecular biology. And then they'll say something like, one of the guys I watched was talking about the ventral glute and how it was another part, a third muscle in your lower extremity. And I was like, the ventral glute? Like, I know that there's a ventral glute where they do injection sites, and I had to look up and make sure that there wasn't a third muscle that I was unaware of.
Yeah,
And
yeah, yeah.
that, like, there's huge discrepancies in knowledge.
Sure.
And that circles back to how, if I was you, I would be more offended by some of, like, when people throw conjecture and poke holes. I'm like, really? Because you're talking about like your ventricular tachycardia or something, like something that's maybe doesn't exist. And I just I'm very skeptical of where my sources are coming from. And through all of our discussions, I'm
As you
now
should be.
just like, now I'm like maybe past the point.
Well, I mean,
Like,
and maybe that's a good place to start wrapping up. Is I told this to a friend recently. Like, look, if you're trying to read studies, if it was done in anything other than a human, you can safely ignore it. You can throw that out, right? If it was not double-blind, placebo-controlled, randomized, you can pretty much safely ignore it, right? So there's really like 5 studies every year, at most, and the rest you can pretty much ignore. And the third one I would say is you know for the stuff we really care about as non-physicians that we care about, in general it should be a mortality study. If it's not a mortality study, it should at least report all cause mortality as a part of the study, right?
right.
And so there's so many studies on cardiovascular this goes back to our thing. It's like, hey, okay, an example I always give about statins, half jokingly, right? But okay, statins reduce your cholesterol. Let's say that every pharmaceutical company is 100% right. There's a massive improvement in your cardiovascular risk profile, but it also makes your muscles weak. And so you're more likely to get hit by a bus because you fall and die. And so there's no change in all cause mortality. It just reduces your cardiac mortality. Well, is that what you care about? Or do you care about all cause mortality? Right? Like, and that's the kind of game that's being played.
Well, so how are we supposed to increase your reach? Because like that statement right there it's so profound. I find it almost comical because it's true. Because like we all get so micro focused on something. Like, oh, if I can decrease this, I'll live longer.
Yep.
And it's like, you know,
At
a
what
good way
trade-off?
to reduce your BMI would be to cut off one of your legs.
Yep. Totally. Yep.
Your BMI will. I mean, I'm
Immediate
obese right
reduction.
now,
Yep.
almost.
Yep.
I could be fit but like you're saying, whenever it's time to evade the predator or step out or whatever other thing,
Yep.
So
I mean, this notion, I think, yeah, is trying to get this notion out, spread as far as wide as we can. Is I think one of my main goals, because that's another great, just like we talked about hair transplant and A1C with blood donation, and this is a great one I would add to my repertoire. Is BMI with leg amputation. Absolutely, it's just not going to change your outcomes, right?
right, right. And if it does, it might be contrary to how you think they're changing. And
Yeah,
that's what we
exactly.
need to dice this up to be. We can
Yes.
the shorts on this should be stuff like that. We should
Yep.
take these shorts and then you need to get someone like you need a polarizing figure and a
Mm.
thumbnail. Tears, violence, police.
My thumbnails kind of suck. That's a side note. We can maybe have that discussion
Yeah, we can.
off
Yeah,
air, but yeah.
yeah, probably so. I have some critiques. I have
Let's
some
let's
critiques.
then let's wrap up here, and we will continue from there.
Well, thanks for having me, Zane. It was good today.